question, is ending tuberculosis possible? I have no conflicts of interest to disclose. Clearly, the question of ending TB is inspired by the WHO's End TB strategy, which has two targets with regard to ending tuberculosis. In 2035, 95% reduction in the number of TB deaths and 90% reduction in the incidence rate. Now, clearly this idea comes from what happened to tuberculosis in the 20th century in high-income countries. This is an example from Europe, where you see a clear drop-off from 1975 to 1990 in incidence of tuberculosis. And what you see here is the notification rates in 2020 in the European Union. And you can see that for the majority of countries, this is below, well below 10 per 100,000. And in most of those countries, half or even more of all tuberculosis cases that are notified are actually imported from high-income countries. So let's start with a bit of history and look at the global TB control strategies that have been there since 1994, when the Dutch strategy was introduced by the WHO, followed by the Global Plan to Stop TB, and then the End TB strategy that we currently have. So the Dutch strategy started again in 1994, had as its objective early diagnosis and treatment of pulmonary TB to reduce morbidity, mortality and transmission. It was based on vertical programs, a really very classical public health approach, focusing on microscopy, smear positive tuberculosis, standardized so-called short course treatment based on isoniazid and rifampin that was delivered through directly observed therapy, and standardized monitoring of treatment outcomes. The decisive argument to introduce DOTS was cost effectiveness, which had been clearly shown in the 1993 World Development Report. There was no elimination target at the time, but modeling by WHO suggested that TB incidence would reduce if targets for case finding and treatment success would be met. Later at that more closely. The Global Plan to Stop TB, starting in 2005, was inspired by the Millennium Development Goals, and it had a target to reduce incidence and deaths by 50% by 2015. It really had a sector-wide approach based on health system strengthening, and it added to early diagnosis and treatment HIV-TB co-infection, addressing HIV-TB co-infection, drug-resistant tuberculosis, smear-negative pulmonary tuberculosis, and involving all care providers. And that was clearly stimulated by the scale-up of antiretroviral treatment, by the addressing XDR and the MDR TB problem, by the establishment of international donor agencies such as the Global Fund, and by technological improvements such as the advent of molecular diagnostics. The NTB strategy from 2015 was inspired by the Sustainable Development Goals, and again with this target of reducing incidence by 90% and deaths by 95%. Following really a patient-centered human rights approach with more focus on prevention, TB preventive treatment, vaccination, systematic screening of contacts and high-risk groups, community and civil society engagement, universal health coverage, social protection and poverty alleviation, and research and innovation, which was clearly important because, as you can see here, modeling suggested that in order to get this decline, which is the blue line here, one should not only use to their maximum the tools that we would currently have, tools meaning diagnostics, treatments, preventive treatments, vaccines, etc., but also develop and implement new tools. So where do we stand currently? This is data from the latest WHO Global TB report, looking at the 2025 milestones and see how far we are with regard to reaching those milestones. Well, the milestone for reduction in TB incidence is 50% by 2025. Currently, we're only at 10%, so clearly below target. For number of TB deaths, we're even more below targets. It's less than 6%, whereas 75% was required. The only one that we are sort of reasonably on target is for reducing the number of people with TB that are facing catastrophic costs. And this is also reflected in these graphs here, which shows you how TB developed over the past 20 years. An important thing to note here is that these are logarithmic scales on the y-axis. So these here show you the estimated incidence in millions of people per year. And you can see that whereas notifications of new and relapse cases have clearly gone up over this period, and actually the estimated number of people living with HIV that have tuberculosis have come down, the total number of people who develop tuberculosis has actually not changed an awful lot. And if we look specifically at Asia, the two WHO Asian regions, Southeast Asia and Western Pacific, you basically see the same pattern. And if we look at mortality, we see that whereas HIV deaths have clearly declined, especially over the past 10-15 years, and thereby also TB deaths in HIV positive people have declined, there has been hardly a substantial decline in TB deaths in HIV negative. Which is not to say that all countries are doing poorly. This is again from the same report showing a number of countries that met the target of 20% reduction in TB incidence from 2015 to 2020. Now, of note, most of these countries are in Africa. In most of these countries, the TB epidemic is actually driven by HIV. So I think that this largely reflects scale-up of antiretroviral treatment. But also other countries have shown some successes. For example, this is in Vietnam, where we compared two surveys done in 2017 to that in 2007, and showed that actually there was a huge drop-off in prevalence between those surveys, both in culture-positive TB and in smear-positive TB. There has obviously been an impact of the COVID-19 pandemic, and you can see that here on the case notifications, a clear drop-off in 2020 that only partly resumed in 2021, with basically the same picture here in the Asian regions. That also translated, according to the WHO, to an increase in estimated tuberculosis incidence since 2020, so the first increase after a number of years. But I think the overall picture should still be that over the period of these three global TB strategies thus far, there has been very limited decline in tuberculosis incidence, at least as estimated by the WHO. The question then is why? So I wanted to try and answer this question by looking at three possible approaches for reducing tuberculosis incidence: early diagnosis and treatment, preventive treatment, and improving protective immune responses. So looking at early diagnosis and treatment, this has been the core of all these three TB control strategies thus far. Its expected effect on TB incidence would be shortening the duration of infectiousness among those that have active TB, thereby reducing transmission. The key requirements would be access to rapid diagnostics, to curative treatment, and to drug resistance testing and treatment. The key bottlenecks to me are lack of effective triage testing and subclinical TB. We'll look more into those later on. As for preventive treatment, that has been part of the Stop TB and End-TB strategies. Its expected effect would be that it prevents active disease and infections among those that have latent TB infection. The requirements are access to prediction tests, to preventive treatment, and to drug resistance testing. And to me, the key bottlenecks are lack of effective prediction tests and related acceptability and cost effectiveness problem. And then if we move to improving protective immune responses, that is only featuring in the NTB strategy. Its expected effects would be to prevent infection and or prevent progression to active disease among those that are already infected. Clearly, what we would need is access to effective vaccines and improved living conditions. And the key bottlenecks here are lack of effective vaccines and economic inequality. So let's start with early diagnosis and treatment. Here there is really a promise versus reality problem. Modeling by WHO, it suggested that TB incidence would reduce by 11% and deaths by 12% per year if 17% of the quote-unquote incident TB cases would be treated and 85% of these would be cured. This was based on, the model for this was based on data from the Netherlands since 1900, as you can see here. And this is the fit of that model to the TB incidence data from the Netherlands from 1950 to 1975. You see, it's a really nice fit. So that model was used, and that came to this prediction that you could actually reduce by 11% per year if you would have 70% of the incident tuberculosis patients detected and start on treatment with 85% success. Now the problem is that it didn't happen, not even in the countries that met those targets for a prolonged period of time, although admittedly case detection was hard to measure. So the question is why? Could it be that treatment was ineffective? Now these graphs are mainly just shown to support these statements here, that standard treatment of drug-susceptible TB until now is quite effective, irrespective of HIV, that second-line treatment of MDR-TB is much less effective, although that is improving with the all-oral regimens are now being implemented, but that in the end only a minority of pulmonary TB globally, as you can see here on the right, it's only 4%, is rifampin or multidrug resistant. So whereas this is a problem, a public health and health problem in general, it does not, multidrug resistance does not explain why incidences are not falling. I think it has much more to do with this problem, which is called the missing millions, which is basically the gap between the number of estimated incident tuberculosis patients per year and number of patients that are notified. Now, if you think of it, this is actually represents three different groups. These are people who are started on treatment but are not notified, for example, because they treat in the private sector. These are TB patients that self-heal or that die, but the largest group probably is those that are not treated and remain with tuberculosis. And that, to me, points to two key diagnostic problems. The first one is about testing those who present with TB symptoms. Now, even though we have all this wonderful new technology, so molecular testing for Mycobacterium tuberculosis, there are a number of problems. One is that rapid molecular testing is not useful in patients who cannot provide sputum. And that's clearly the case with many people who have HIV and with children. But probably more importantly, rapid molecular testing is being used only on a subset of patients who would benefit from testing. And that is because it's practically impossible to test everyone who presents at, for example, a busy clinic who have prolonged cough. And it's also unaffordable to do that. I don't show you any data here, but I have many studies that show that. So that means that we need a different approach, and we need probably an approach that is based on triaging. So the idea of triaging is that you have a test that is cheap and that is simple to use, and that can basically divide those people who come with symptoms into those that have a high likelihood of that the symptoms are due to tuberculosis versus a low likelihood. Those with a high likelihood are then tested with the more expensive molecular test. Now, importantly, for an effective triage test, it needs to have an optimized sensitivity, and its specificity is then a trade-off with cost. Now, there are a number of candidate tests that may make it into triage tests that could be scaled up. One is C-reactive protein, CRP. This is data from a systematic review of CRP as a triage test for TB among people living with HIV that was published last year. You should look here at the purple line. So this shows a sort of reasonable, in this ROC curve, a reasonable test performance. But the problem is that you really want it to be here. So this is you want to have a very high sensitivity at a reasonable specificity, and CRP, at least according to these data, clearly does not reach that requirement yet. One that was published more recently is more promising. That is a host response cartridge on the GeneXpert platform that tests for an RNA signatures by fingerprint blood. But the problem here, obviously, that it is much more expensive. So the question is whether it would ever be useful as a triage test. So what we really need is disruptive technologies. We need, for example, breath testing, or we need something that we are currently developing with a group together in amongst other, South Africa, where we are looking to develop a cough classifier, so that classifies cough sounds into low versus high probability. That's actually tuberculosis, and that can be used on a smartphone. But it's obviously a long way to go here. The second diagnostic problem that I want to draw your attention to is this one, testing those who don't present with recognizable TB symptoms. And we've become more aware of this problem with all these tuberculosis prevalence surveys that have been done worldwide for the last 30 years. This is from a systematic review of those surveys, and what it actually shows is that about half of all individuals who are diagnosed with tuberculosis in these are community surveys, actually do not present with prolonged cough or any other symptoms, which in this study was the definition of subclinical tuberculosis. And as you can see here, there is some variation, but not a huge variation between surveys and between African and Asian surveys. And importantly, also, it is not clearly associated. Those are these black crosses here with the prevalence that was measured in the survey. We are looking at this more closely. So this is data from an individual participant data meta-analysis of 12 of those surveys. And Logan Stuck in my group actually is now showing that more than a quarter don't have prolonged cough, but they do have cough of shorter duration. So probably on and off cough. And a half or more have other symptoms. Women and young adults more often have TB without that prolonged cough, which is his definition of subclinical tuberculosis. So the question then is, what is the clinical fate of this subclinical tuberculosis, and is it infectious? With regard to the clinical fate, this is modeling that is based on data that was retrieved by a systematic review of pre-chemotherapy studies going all the way back to the 1930s. And here a cohort of individuals with subclinical tuberculosis is modeled over a period of 5 years. And what you see here is that after a year, about 45% of these have either died or have developed clinical tuberculosis, or have developed, and that's the largest group, this so-called undulating tuberculosis, which means on and off symptomatic, on and off with cough or whatever symptoms were used at the time in those studies. And after 5 years, you can see, whereas 2/3 have actually either completely recovered or almost recovered with only very minimal disease on the chest X-ray, about 1/3 actually has clinical disease or died. So yes, it is clinically important. Now, there are a number of studies that are coming out now looking at infectiousness. This is a study that we were involved in Vietnam, looking at tuberculin skin test reactions in children that had in a prevalence survey, a household member that was diagnosed with tuberculosis. And what you see here is relative risks of having a positive tuberculin skin test in these children compared to households that had no TB index patients. And you can see that in those households where there was a TB index patient that was smear positive without symptoms, which was without prolonged cough in this case, the relative risk, 3.11, was almost similar to that in households where there was a smear positive index patient that had clinical tuberculosis with prolonged cough. So that is a clear indication that subclinical tuberculosis might be infectious. And this is data from another study that will come out soon that used data from this study in addition to two similar studies plus one intervention trial that actually suggested that when adjusting for smear status, subclinical tuberculosis is no less transmissible than clinical tuberculosis. So yes, subclinical tuberculosis is important. So how do we address this? One option is to have improved clinical algorithms. This is again data from our group, and that shows that this is from Zambia, detailed data that showed that 78% of those that had no prolonged cough but did have culture positive tuberculosis actually had other symptoms, and especially as you can see here in the 2 weeks before the survey. And that brings us to the question, can we develop effective diagnostic algorithms that do not depend on prolonged cough and potentially incorporating inexpensive triage tests? And the other approach, obviously, would be chest X-ray screening, because we know that chest X-ray screening had been used massively in the 1950s, 60s, and 70s in those high-income countries that managed to reduce tuberculosis. Actually, the Dutch data on which these DOTS targets were modeled partially reflect mass radiography screening. There was a lot of mass radiography screening in the Netherlands during this period. And this is data from Sabine Hermans, also from our group, that looked at 100 years of notification data from New York, London and Cape Town here in red, where you can actually see that the only period during which there was a clear drop-off in TB notification in Cape Town was during the period when there was mass radiography screening. Now, obviously, this is very circumstantial evidence because at that time there was also a change in intensifying of the apartheid regime, but it points to a possible causality. Clearly, there are now a number of developments that make it possible to do chest X-ray screening at a much larger scale. There are portable, for example, here very portable systems. The development of computer-assisted radiography, by which you don't need a radiologist, also provide much more opportunities for mass chest X-ray screening. So the question here is, can we develop cost-effective strategies for mass chest X-ray screening? Now, moving to preventive treatment regimens are becoming shorter, more and better tolerated. And the WHO advocates scale-up of TB preventive treatment in people living with HIV, household contacts of infectious patients, and other people at risk. And it's important to note that with the exception of people living with HIV and children who are contact of an infectious TB patient, in all other groups there is still a requirement for testing for tuberculosis infection. And that brings us to this problem, that is that with the current test that we have, tuberculin skin test and interferon gamma release assays, the positive predictive value, so the number that have a positive test and in the end develop tuberculosis over a period of 1 to 2 years, is only 2 to 4%, translating into a number needed to treat in order to prevent one case of tuberculosis disease occurring of 25 to 50, which is clearly not cost effective and not acceptable at scale. So the question is, can we reduce that number needed to treat, for example, by being able to identify a group that has so-called high-risk latent TB? This is potentially possible, for example, based on the data here from the South Africa adolescent cohort. So what this shows you is here at the time point, this is when TB in these adolescents was diagnosed, and then it looks back in time at the various changes. And you can see here that from about 360 days, from about a year before TB is diagnosed, there are all sorts of changes already identifiable. For example, inflammatory responses, including interferon, complement cascade changes, monocyte changes, and CD4 subset changes. There are a number of potential markers already being identified. One is the monocyte to lymphocyte ratio, which has been studied in a number of populations. We looked at it here in Bangkok with the HIV-NAT group with Sivapur and Katachompol, and she actually showed that in their cohort the monocyte to lymphocyte ratio is a strong predictor of TB developing over the next 6 months. If you can see here at a cutoff of more than 0.25, which is the highest quartile, you actually have a 9 times increased hazard of developing tuberculosis. This is data looking at another potentially promising biomarker, the carnitine to tryptophan ratio. This is in an HIV cohort from South Africa, where the KT ratio predicted TB occurring 6 months before the TB diagnosis was made. This is TB cases comparing heater controls. Even though Sivapur here in her cohort here in Bangkok, it does not confirm all these findings. So these better prediction tests probably reflect what we nowadays call incipient tuberculosis. And just to remind you what that was, so if this is time and people start with having latent TB infection here and end up with having clinical tuberculosis here, then they probably go through a number of stages which may have different durations. And the stage of incipient TB is defined by not yet having positive sputum culture, but already potentially having positive imaging, for example, on PET-CT scans and potentially on chest X-rays. It's important to realize that people can actually move up and down spontaneously without any intervention between these various stages. Now, one of the reasons why we think that this is the case, that this really reflects incipient TB, is what is happening with the host RNA prediction signatures. There's a lot of these signatures being developed and been evaluated, and this is data from a head-to-head comparison of 17 published signatures, of which you see here the data from the 8 best performing signatures. So these are again these ROC curves, and what you see is that when you go from a period of between 0 to 24 months between testing and TB diagnosis, to a period of 0 to 3 months between testing and TB diagnosis, the performance improves. So the curve goes more to the left upper corner. And this is saying the same thing, but now in terms of positive predictive value. At a pre-test probability of 2%, these tests can reach a 10 to 15% positive predictive value, but only if it's tested closely before onset of TB disease, so 3 to 6 months before onset of TB disease. And that brings us to this problem, and this is an expectation versus reality problem of these incipient TB tests, so improved tests. So the expectation would be that these incipient TB tests allow better targeting, so with a higher positive predictive value for progression to TB disease of TB preventive treatment. And then came the Cortes trial. The Cortes trial was done in South Africa and was a trial of over 1,100 healthy adults who had been tested for one of those signatures, the risk 11 signature. And those that tested positive were randomized 1:2 to 3HP or placebo and followed up for incident TB over 15 months. And this is what came out of it. So here you see the Kaplan-Meier curve, and you see there is not an awful lot of difference between the blue line, which are the ones that did not get 3HP, and the ones that did get 3HP. The treatment efficacy over this period was only 22%, it was non-significant. But there seemed to be a bit of a shift, as you can see here, over time. And when this was expressed as the treatment efficacy over time, it suggested that there was a perfect treatment efficacy over the first 9 months, but then a quick drop-off. So this suggests that standard TB preventive treatment delays TB disease, but doesn't prevent it. So that suggests that biomarker diagnosed incipient TB may represent higher loads of multiplying bacteria than what we would generally see as latent tuberculosis infection. So it probably means that we need to treat with something different. We can't just use the standard, these very short, effective LTBI regimens. We probably, in this subset of patients, of individuals, probably need to give something that is something like 3 months of full course treatment. And that, to me, is the paradox of incipient TB testing. So that sensitivity is the highest in here, very close to the onset of tuberculosis, which means that we are probably, when we're testing, we're probably not testing for something latent, but we're probably testing for something that should be framed as early tuberculosis. Now, the problem is that here these tests also have a pretty low specificity, or actually too low to say, well, let's treat everyone who has a positive test with 3 months or, for example, 4 drugs. That is probably too low. And that has to do, and this is looking at this risk 11 score in the Cortes trial, that actually there's a lot of waxing and waning over time of these RNA signatures and potentially other prediction biomarkers as well. And in this case, it was very much associated, as you can see here, with viral infections. So apparently, respiratory viral infection produces a positive risk score. So this is a problem that we're facing. So Then, why could early TB be important to detect and treat? I think that is because of MTB and aerosols. So there have been a couple of studies now. One has been looking at aerosol sampling through face masks. So these are face masks that contain a filter that capture Mycobacterium tuberculosis and can then be tested with a PCR. And these studies actually showed that face mask sampling in these studies that viable Mycobacterium tuberculosis aerosolized irrespective of cough and irrespective of sputum bacterial load. In very early stages, people may already be infecting. There's been a similar study looking at aerosol chamber sampling that is hopefully coming out soon, that suggests that presumptive patients with sort of issued read negative sputum experts still shed viable Mycobacterium tuberculosis. We know from other studies, I was going to say we know from other studies that these aerosolized tuberculosis can actually be infectious. Now coming to improving protective immune responses, first looking at new vaccines. Now I've shown you this last year. This is the pipeline. Whereas it looks promising in phase 2 and phase 3, it's not that promising. Most of these vaccines are actually live attenuated vaccines which have all sorts of limitations. There is actually very little here in the early phases, so that means that we really need to diversify the pipeline. The problem here is that this shows you the timelines of those vaccines that are currently in late-stage clinical development, including, this should read M72. And you can see that we are looking at probably 5 to 10 years before any of these vaccines can licensure. So that means that we're left with the other one, that's improving living conditions. Now, it is for a long time been clear that tuberculosis is very strongly associated with poverty. And actually that association is found at any level that you look. For example, this is looking at a country level. This is looking at TB incidence here on the log scale on the y-axis and per capita GDP per country. These are countries on the x-axis, also on the log scale. And you see that it's very strongly correlated. And actually the rich countries, and this is again these data from the Netherlands, already saw a strong decline in TB incidence long before effective treatment became available, which was in the 1950s. We already saw this strong decline, which is probably just due to improvement of living conditions. And to me, a real eye-opener was a study that came out in 2009 that looked at trends in TB incidence in 134 countries by the WHO. And that showed that a decline in TB incidence over that 10-year period was not associated at all with any indicator of tuberculosis control efforts, but only with indicators of economic development, like the Human Development Index and the under 5 mortality. So that brings us to the question: what drives this striking association between poverty and TB incidence? I think one real eye-opener is this one here. There's a very clear association with undernourishment, and I don't think we completely understand why this is. Obviously, we know how this is for HIV infection and to some extent for smoking and diabetes. And probably many other factors play a role here as well, as poor housing, poor working conditions, stress, social inequality, and so forth. And I think in as much as it is important to address these issues as such, I think poverty should be addressed. It's also important to understand these associations, because it may well be that poverty-related risk factors may also reduce the effectiveness of new TB vaccines. So that brings me to an attempt to answer the question: is ending TB possible? Rich countries have seen remarkable declines in TB incidence, so ending TB is possible, at least so it seems. At the global level, however, ending TB will only be possible if we bring TB diagnostics to the community, triage testing, if we combine early diagnosis and treatment with effective mass screening to deal with subclinical TB, and if we shift our attention probably from preventive treatment to early TB treatment. But we may not achieve that unless we develop and provide access to an effective TB vaccine, and unless we deal with poverty as the key driver of the epidemic. But we must keep trying. And with that, I would like to thank you for your attention, acknowledging these people who have been involved in the various studies that I showed. Thank you.